PFACs improve safety, enhance the patient experience. They also save money. Unfortunately, PFACs are only in 54% of all hospitals, according to the American Hospital Association. So my vision is a PFAC in every hospital, and I would love to see a PFAC in every department.
Hello, I'm Chris Malone, and I'll be your host for today's discussion. Thank you for joining us. And I'd like to start by welcoming Jill Adolphe to the program. Jill is chair of the Global Patient and Family Partnership Council for Planetree, which is a not-for-profit organization dedicated to humanizing healthcare for everyone through excellence in person-centered care. I'm pleased to have Jill as my co-host today, thanks to her deep expertise on patient and family advisory councils. Welcome, Jill. What can you tell us about our guests today?
Thanks very much, Chris. It's great to be joining you today. Dr. Barbara Lewis is a healthcare researcher and advocate best known for helping hospitals launch and strengthen patient and family advisory councils, known as PFACs, to elevate the patient voice. She is founder and president of Healthcare PX, a nonprofit that provides practical training, research, and tools for PFAC leaders and hospital executives, and hosts a robust webinar series on PFAC strategy and measurement. Lewis earned her PhD in Health Service Management and Policy from the University of Nevada, Las Vegas, where her scholarly work focused on PFAC adoption, accelerators, and outcomes. Her research has appeared in peer-reviewed outlets, including studies on PFAC success metrics. A former journalist and UCLA MBA, Lewis translates evidence into action for health system leaders, emphasizing how to demonstrate PFAC value through metrics and financial impact. She has co-chaired the Barrel Institute Global Patient and Family Advisory Board and served on Kaiser Permanente's Southern California Regional Patient Advisory Council, and is a frequent keynote speaker and webinar host on PFAC governance and measurement. Welcome, Barbara.
Thank you, Jill.
Great to have you, Barbara. And so, Barbara, to get us started, I would really love to hear the story of how you found your way from a career in journalism to now having a PhD in health services management with a focus on patient and family advisory councils. How did all that come about?
Well, I spent 2 weeks in the ICU with my sister in 2012, and she had been admitted with an unknown infection. So I was sitting at her bedside for 15 hours a day, living in the motel next door, researching this unknown infection, talking to experts all over the country. As Jill mentioned, I was a former reporter, and I was teaching primary research at UCLA Business School. So I was heavy into my research on what could be wrong. And every morning I went to the family meeting and I talked about what the experts had said and my recommendations. And I was completely dismissed. Nobody would listen to me. As a matter of fact, one hospitalist said to me, if you want your sister to die, we'll take her off that medication. I did find out a few days later that they did take her off that medication and, in fact, adopted all of my recommendations that I had. But unfortunately, it was too late for my sister. She passed away very tragically. So I came away from that experience and I said, where's the patient voice in hospitals? And I started doing research and I found the Patient and Family Advisory Council, otherwise known as PFAC. So I decided to close my marketing company and devote the rest of my life to improving the patient experience. So I immediately looked at my own hospital, Kaiser Permanente. They had a PFAC. I joined it, then went to the Barrel Institute also as their co-chair. And I found that in this journey that I had, that people did not know that much about PFACs. And when they did, one person said to me, but where's the business case? So I had an MBA and I'd written lots of business cases. So I said, let me write the business case, which I did with anecdotal evidence. And about 5 or 6 years after that, I said, well, that research is getting sort of stale. Why don't I go back to school and get a PhD with my dissertation on PFACs and do some research? And I did 3 studies. One was a literature review of hundreds of articles. The second one was a qualitative study where I interviewed 20 leaders about their outstanding PFACs. And the third one was a couple of hundred people who answered 60 questions, quite extensive, on a quantitative survey about PFACs.
Wow. So I'm so sorry to hear that, what you suffered with your sister and so forth, but it sounds as though you are really making a difference as a result of that tragic event, and that's really to be applauded.
Thank you very much.
Barbara, how do you define success for a PFAC? What metrics or indicators best capture whether a council is making a real difference in patient experience or outcomes?
So, Jill, the very interesting thing about this is that you can ask 20 people what is successful for them or how they would define success, and you would get 20 different answers. And indeed, I did in doing the research. One person said to me, oh, it's the recruiting. And another person said, well, it's the retention defines our success. And a third one says, well, it's the amount of content that we have on the agenda. But from my standpoint, after all this research that I've done, including 10 years ago, so I've been at this research for over 10 years, I look at measurement as success. And the Agency for Healthcare Research and Quality has on their website, ARC, 3 different types of measures. One is process, and that's about numbers. And the second one is structure, and that has to deal with capacity. And the third one is outcomes, and that's about finding out what the difference is before the PFAC was involved and after the PFAC was involved. So those metrics can be applied to 3 different areas. One is feedback from the PFAC itself. What did they think of the meeting? The second one is feedback from the presenter, from the departments that go. And the third one is the initiatives, the outcome. And they can be both quantitative and qualitative. So in the survey that I did, I found that 33% of respondents were using process metrics, the number of meetings, the number of people, for example, but only 10% were using outcome metrics. And I actually have an article in the Journal of Patient Experience on metrics. And to me, that's the most important way to define success.
And what kind of metrics or outcomes are measurable? Is it like infections or what kinds of things have you seen that were measured and reported as outcomes?
Well, there's many types of outcomes. I've seen tons of examples of outcomes. So, for example, the number of falls. A lot is around communication. What were the discharge instructions before and after? Did we get as many calls as we used to after we changed the discharge instructions? Some things can't be measured. For example, wayfinding. That's very hard to go to people and say, okay, what was your experience finding your appointment or finding that department, and then put up the signage and say, okay, what is it now? I mean, it can be done, but it's just not as easy to do.
Yeah. Now, it's my understanding that many hospitals struggle to kind of sustain their momentum with PFACs after the initial enthusiasm fades. What are you seeing as some of the barriers that cause that, and are there things that leaders can do to overcome them?
So the number one barrier that I found to retaining members is that hospitals are not closing the loop. And this is very important to tell the people who have volunteered their time and their brain to give recommendations and suggestions about the results of what happened when they gave those recommendations to a particular department about an initiative. And one person told me that she had somebody leaving the PFAC, and he was an excellent PFAC member. She sat down and asked why, and they said, well, I don't know what happens. You know, I give you my suggestions and I never know what happens. So I was talking to someone about this, and she said, well, you know, they can go in the hospital and they can see what we've done and the impact that we've had, thinking, no, we should not expect our PFAC members to wander around the hospital and see the results of what they did and their contribution. So a lot of hospitals have 2 parts of an agenda. One is the new initiative that comes and asks for input, and the second one is a returning department from 3 to 6 months ago that comes back and says, here's what you told us, and here's the changes that we made. And oftentimes what I find is that when they come back, they say, oh, and by the way, we have additional questions on a new initiative that we have, or the same initiative. But it's very important to close the loop. And I think that's one of the most important barriers that I've seen in retaining members.
Makes sense.
Barbara, what practices separate high-performing PFACs from those that remain largely symbolic or underutilized?
Well, it's very surprising to me that PFACs are not measuring much. Now, some PFACs measure everything, and they're really good with the metrics, but there's a lot of PFACs that are just not proving their value. And I found this out in the first research project 10 years ago when I found that 3 hospitals actually closed their PFACs. And I couldn't understand this. I'm advocating more PFACs, and now all of a sudden we have hospitals closing PFACs. So I went out to each of them and asked them, what happened? And they said, oh, a new CEO. And I thought, oh gosh, the new CEO comes on board, said, what is this PFAC and what do they do? And they couldn't prove the value probably. And they said, well, we don't need this. So it's so important to prove the value and then to tell the patients, let's put that in a newsletter that goes out to the patients that we did not get good scores on our food, but we took our chef and food to the PFAC. They tasted it. They gave us a lot of suggestions of how we should do the menu, etc. And now our scores have improved. We listen to the patients. So talking to the patients about the fact that you're listening, telling the rest of the hospital too, with an internal newsletter that which departments came and what the input was and what the result was. And of course, going out to the community and saying, we listen. So I think that's really important as well.
Well, that's a great example of something they could show tangible movement on. Are there any other ideas you have for PFAC leaders that how they can demonstrate financial or operational value to executives, particularly if there's a new CEO, where sometimes they may view things related to patient feedback as more of a soft metric?
Yes, too bad it's a soft metric, and that's what people do consider too. So there's 3 things that I found: that PFACs improve safety, that they enhance the patient experience, which includes age caps, and that they also save money. So in 2 instances, 2 hospitals went out to an e-advisor list and asked about putting a clinic in a particular neighborhood. And in both cases, the respondents from that zip code said, no, don't. We want to go to the hospital. We're used to that. We want to have all the bells and whistles and everything that goes on at the hospital. We don't want to sit in a clinic. We can drive. So the hospitals were really surprised about that. And then a second one having to deal with money was $500,000 worth of infusion chairs, or chairs for the infusion department, let me say that were going to be installed. And they brought the chairs to the PFAC, and the PFAC said, no, we don't need all these different things with the chairs. We bring all our own devices. We need electrical outlets. And then the 2 people with diabetes, when they laid back in the chair, the bottom of the foot cut them at their calf. And it hurt, not actually slice them, but, was right there at their calf, and it was not comfortable for them. So they saved $500,000. And both of the other ones, both H caps are, of course, tied to money, as are improving safety. Any safety issues, that's also tied to money. So let's say you have a lot of falls and you want to figure out what to do about it. Go to the PFAC and ask them, how can we improve and decrease the number of falls that we have? Well, that's tied to money. Last I looked, it was between $15,000 to $65,000 per fall inpatient. So everything is tied to money, most things. We're just not getting there and analyzing it. And we need to do that for the CFOs and the CEOs to prove the value.
Good points. Good points.
PFACs aim to represent diverse patient voices, yet inclusivity can be challenging. What strategies have proven most effective for recruiting and retaining diverse council members who truly reflect the communities served?
So this is an issue, and I won't even say across the country. I'm going to say across the world because I've talked to lots of people around the world, and it's all about recruiting, and we can't get diverse members. Some hospitals have solved this conundrum very well. But generally, what people have told me is that oftentimes PFACs are comprised of older white women, and they're trying to diversify. So here's what people are doing to diversify, what hospitals are doing. They're using the electronic health records to find specific people that they want, and they're going out to community groups that reflect the demographic or the condition, let's say, that they're looking for. The other thing that I found is that hospitals oftentimes, when they identify the correct demographic that they need, they'll ask two people to join. And this is really good because research shows that having two people is much more comfortable for the people to speak up than one person. So there's some hospitals that say, we are searching for a demographic, we're going to get two people, which I think is really a good idea. And I think you asked about retaining them. So it's not so much about retaining diverse members as much as just retaining members, I think, in general. One of the things that is so important, and really the silver lining of the pandemic, which is strange to say, but we went from 100% in person to 100% online. And now we have a lot that are hybrid. And as a matter of fact, the only PFACs that I could find in person were geriatric. And I think this might be because of the technology challenge and because of the interest in socialization and combating loneliness. But having a hybrid council allows us to democratize a PFAC and really get the diverse members that we're looking for.
Got it. Got it. So now if we've got well-recruited, well-represented, diverse forces on our PFAC, how do we ensure that they are integrated into the governance and decision-making rather than just kind of being siloed into some kind of advisory role?
So PFACs are advisory. You know, this is not a democracy where patients vote on something and then the most votes wins over between the leaders in the hospital and the patients. It's an advisory role. And I think that there's some patients that don't understand this. They think that whatever they say will be adopted, and that's not the case at all. That's very important in the training of PFAC members, that they understand that this is an advisory. Their opinion, their feedback is sought. The leaders really set the tone from the top. And I think that the mantra, nothing about us without us, which some hospitals have adopted, is really good, that every patient-facing project needs a patient involvement. So you can put patients on committees and work groups as well, but all of those people need to be trained, both on the patient side of how to tell their story, for example, very succinctly, and also on the employee side. So you don't just send somebody to a meeting on this day at this time in that room and have them show up. The groundwork needs to be laid with the employees of the hospital, for the committee and the work group, as well as training the patient on what they'll be doing as well.
Thank you.
Barbara, your recent studies have explored PFAC accelerators and outcomes across hospitals. What are a few of the most powerful accelerators you've identified? And how can patient experience professionals leverage them?
So one of the very interesting things that I found that has never been discovered in any kind of research previously is that the more effective PFAC is one that is a focus group as opposed to an unfocused. So an unfocused group is one that's just a general PFAC that might be for the hospital, for example. A focus group is both condition and population. So it could be a diabetes, it could be cancer, it could be people over of certain age, or it could be youth, for example. And the research showed that the focus PFACs were much more effective in about 10 different areas. And those included more content, more meetings, more pre-meetings, and pre-meetings is very important. And I think we have a question coming up about that. More measurement with both process and outcome metrics, and the higher engagement level where PFACs are not just a stamp of approval, but that they're more involved in the design, in the co-design of it. So one of the things is if you're starting a new PFAC, think about having a focus PFAC in a particular department, for example. The other thing that I found is that the process of the PFAC is important in terms of the pre-meeting, the during the meeting, and also the end of the meeting, or post-meeting, I should say. So post-meeting, we talked about the different types of surveys that can be done. That's so important. But the pre-meeting is important because this sets up the department that's coming with their initiative to talk with the PFAC. And I'm surprised that a lot of I think it's 25% only of hospitals have pre-meetings and the rest do not. And this was very surprising to me because I thought if you're inviting somebody in, wouldn't you want to meet with them ahead of time? And someone said to me, well, we were having a leader come in and we really didn't think that we had to prep the leader. Yes, you have to prep everybody. And what that prep is, it's about the number of slides that the person is using, the acronyms, and also the questions that are going to be posed to the PFAC members as well. So that pre-meeting process is very important. And then the during meeting process is all about managing the members, giving them storytelling tips so that they don't go on for 5 minutes when something can be said in 2 or 3 sentences, for example. And I also found that there's some issues with the way that people act in meetings, and mainly it's because they just have not been trained. They raise their hand, you're on the PFAC, and you're just expected to act a certain way. And a lot of people have never been in a business meeting, and so they're not familiar with the way that PFACs are run, and they need to be educated.
Yeah, so it sounds like there are a lot of best practices as to how to make PFACs more effective, but I gather that perhaps there isn't any kind of standardized operating manual that people, can access that tells them how to do this. Perhaps your articles are addressing some of this, or does that kind of resource exist to guide PFACs on these best practices?
Yes. So it's not just my articles, but I have put together on my website what needs to be done. So, for example, I have a step-by-step process if you're starting a PFAC. Okay, what's the first thing that you do? Or what's the 30th thing that you do? And it just goes through every single thing, what you need to do.
Looking ahead 5 years, how do you envision the role of PFACs evolving, particularly as hospitals integrate AI, digital health, and new models of care?
So unfortunately, PFACs are only in 54% of all hospitals, according to the American Hospital Association, which in their comprehensive annual survey has been asking this question since 2018. So my vision is a PFAC in every hospital, and I would love to see a PFAC in every department. And in fact, there are hospitals, freestanding one facility hospital, not a system, that has 30 PFACs, which, that's in a lot of different departments, a lot of conditions, a lot of population that they're reaching, and it's very important. When you look at other industries, there's always lots of feedback from customers. You can fly and get a survey. You buy a computer, you get a survey. You take your car in to be, and you get a survey. But we've been very slow to do this in healthcare, and we need to ask our customers, our patients, their feedback. And I think that eventually what we're going to do is that we're going to have the personalized feedback where my chart and the after visit summary, which is in about 50% of clinicians use after visit summaries now. that we're going to be able to put that information in there of what our opinion was. Okay, so I got the after visit summary from the surgeon, but what was my opinion of that appointment? Well, the surgeon had their back to me and they were typing on the computer and looking at an x-ray and said, oh, this spot might be cancer. So we need to do something before we have the surgery. And I nearly fell off the table. So what I would do is write that in after visit summary. We could do that. We can't do that now, but and then I would say, okay, what is my recommendation? They face me. They tell me, which he told me later. He said, oh, this is very common. It's a precaution. We don't have to worry about it. Okay, that's my recommendation for what they should have done. And the benefit and the result for me would have been that I would have eliminated a week of needless worrying myself sick. So I think that we're going to have an agentic AI that will go into the after visit summaries, pull out all that information, put it into a dashboard, and talk to the clinicians specifically, the departments, and the hospital about what can be done to improve. I think AI is going to have a tremendous impact.
Oh, it will be interesting to see.
Yes.
Now, I think you mentioned to me before that only about half of hospitals have PFACs. And so if you were to offer advice for those that might like to start a PFAC, what would be, your key, advice, or those, alternatively that have one, what advice would you have to, kind of the top things, either watch outs or things to do, if either starting or reinvigorating at their hospital?
Okay, so if you're starting one, I actually built a computer algorithm, and it's a readiness assessment that a hospital can fill out to see if you're ready to start a PFAC. And then, as I mentioned, I have a step-by-step process because it's a little confusing to start one. I mean, what do you do first, So I will send a hospital that's interested in starting one that I'm working with a list, and then we'll go through that list one by one and accomplish all of the objectives so that they are ready to start. In terms of retaining or revitalizing, as you said, I think that the number one thing is leadership support. I mean, it's very important. There are PFACs that exist without leadership support, but they're very rare. When you have the leadership support, it permeates the organization, and everybody knows that they should be using patients for feedback. They are the customers. We need to understand what they want, what they think about care delivery. So the leadership support is very important. And now, I've done probably a half a dozen articles on, some peer-reviewed, some not, on this subject. So the research exists now. And I think it's easy for people to understand how important the PFAC is and how much it can improve the organization.
Great. Now let's turn to some of the questions that listeners have submitted. And I think some of these topics we have touched on a little bit, but I do want to mention as many as we can. From Carlos Montalvo, he was asking about recommended strategies for effectively recruiting PFAC members. You touched a little bit on this as relates to diversity. Anything else you would add to what you mentioned before on that subject?
Okay. So here's some methods. So I mentioned the electronic health record, which is very important. That's where people are recruiting from. So number one, 20% of the respondents said word of mouth. Clinicians' recommendations, grievances, pamphlets, social media, hospital entrance. Sometimes hospitals will set up a table, a visit to the wards, and the after visit summary. Why not put something in there? We're looking for people. Those are some of the ideas.
Thank you. Also, we've got a question from my friend Lori Verlingeri. How do you view the difference in value between in-person PFAC meetings and groups versus a model that is online PFAC surveys? You mentioned a little bit about this, about the move to online. Any trade-offs there in your view?
Well, generally what I found in the research that I did is that the online surveys are precursors to the in-person or to the, whether or not the in-person is online or actually in person. And that is that the surveys could be anywhere from 1 or 2 to maybe 10 questions. And then those results are then brought to the PFAC for more in-depth conversation.
Mm-hmm.
So it's a great way to find topics for an agenda that you may not want to just ask the PFAC, how many of you want to do this or how many of you think that? You go out to a lot of people, ask them the question, and then find the nuance of those answers in the PFAC meetings.
She had a little bit of a follow-up, and I wanted to get your thoughts on this. Do you have any advice for a previously very active hospital-wide PFAC when the new administration has moved to a model of surveys and they say, we'll reach out to you for work groups, kind of thing? Is that something you've seen as well?
Yes. And that's becoming increasingly popular. So the surveys go out to a large group of people or everyone in a particular category. If you're looking for somebody to women on this particular subject, go out to everyone. And then you want to form a work group around that. And a lot of hospitals are doing that now. Instead of just having one dedicated PFAC, they have work groups on specific subjects. And so my research saying that focused PFACs are more effective than unfocused PFACs sort of supports that theory that the work group would be very effective and more effective than the general PFAC would be answering, further questions.
Got it. Julie Strider-Cook asked, can you tell me more about community groups? Is that something you mentioned?
Okay, so community groups of where you're going out to recruit can be, for example, a particular type of population. So maybe you don't have that many Black people on your PFAC, and the PFAC is not looking like the waiting room is looking, right? So you could go out to perhaps the Black church and find people. Or if you're looking for a particular, so that's the population side. If you're looking for a condition, for example, going to a group that might be dealing with oncology in the community or some kind of a support group or something, going to them, talking to them about what the PFAC does, and then asking them if they would like to participate.
Now, Aisha has been patiently hoping that we get to her questions. She asks, can we please discuss what training topics might be provided to PFAC advisors to optimize their effectiveness as advisors?
So the training of the PFAC members, that is storytelling, which is very important. And in storytelling, the way that one hospital laid it out is problem, solution, benefit. Okay, you talk about your problem, which is what I sort of modeled in the surgeon interview or surgeon appointment that I was having. You talk about your problem for a couple of sentences, then you talk about the recommendation of what you would do differently. So in my case, the surgeon would face me and talk to me rather than typing on the computer. And then the last one is the benefit, and that is what happened to me between the difference of those two ways that it was done. So actually talking through the problem, solution, benefit, and that has to do with storytelling. So then the other thing is training for round robins. One person raises their hand and then everybody speaks, because what we find in certain groups that some people are more vocal than other people. And so they're always talking. So we don't want the same people talking all the time, but a round robin ensures that everybody gets to speak. I've done a couple of trainings on metrics to help inspire the PFAC understand that it's not just giving things off the top of their head, that they should push the departments to measure before and measure after and come to them and tell them the results too. So training in terms of metrics, which is so important these days to prove the value, is also important for advisors as well.
Also, we've got questions about compensation for PFAC members. SK and Aisha both asked about, how do you incentivize PFACs? How can we recognize our advisors, and what compensation might we provide other than money to facilitate their participation?
So this is a tricky one. Almost all hospitals that I've talked to and surveyed do not give any kind of compensation. They may give a gift at the end of the year. They may give a gift card occasionally. Two hospitals do pay. One pays $50 an hour, and the PFAC members are expected to log into a portal and write down their hours, and they're paid monthly. And then others give a stipend of $25, for example, for each meeting to cover transportation and also babysitting or whatever else. I think that we're never going to move beyond compensation, no compensation, which generally is what's happening these days, unless we can prove our value. So if we say that this PFAC spent 2,500 hours over the course of the year looking at various projects, and that the return on investment, the money that we saved the hospital was X amount of dollars because we decreased falls or we improved discharge directions and there were less hospitalizations, whatever it was, unless it's tied to money, we're not going to be able to prove that the patient and family should be paid. And a lot of people think that they should, but there's no proof of concept for this. So we need to, again, prove the value. It's all about metrics. Do I sound like a broken record, Chris?
Well, it's a consistent theme. An anonymous attendee is asked, can you share the names of institutions who practice the gold standard of PFACs along with top performing in HCAHPS and clinical outcomes? Any organizations that you would recognize as high performing in those areas?
Yeah, Kaiser Permanente is definitely far and above most other PFACs that I've seen. So I was on theirs, and I might be biased, but they are a very process-oriented organization to begin with. So there's process involved with everything, and that includes the PFAC. And they have a lot of best practices. To me, they're like a lighthouse of what's happening. And some of their PFACs are very into measurement and, are proving their value all the time.
Got it. We've only got time for one or two more questions. We do have one from Kay Campanerio, who asks about why some states do this legislatively, as they have in Massachusetts since 2010, and, why don't other states do it, or what can be done about that?
Yeah, that's a good mission that I have been thinking about, except that I don't want to go to 49 other states and do it. So I'm thinking about how can I do this federally. So it was a long journey. I've actually written an article about that I think is on my website. And it happened in 2010, which is a while ago. The climate was just exactly right for doing it. And I don't think it's come up in any other states, but I've been thinking about how can we do this? How can we legislate this so that patients and families are listened to and are part of a hospital system? I'd rather have the hospitals embrace this because they find value in it than be forced to do it. But if they're not going to embrace it, maybe we should force them because 40 years and 54% is not a great record.
Yeah. So this will be our last question. It's from Abdullah Asari. He says, I represent a big organization with various services, and now I like the idea of a focused PFAC. Should we create mini PFAC for each service, and is that likely to be more effective? What do you think, given your earlier comments?
Yes. Yeah. According to my research, it'll be more effective. But I would start with a pilot first, because you want to prove the value, and one where they're very patient-centered and where they're very interested in doing this. And one of the things that I didn't mention is that when you have a champion of a PFAC, and that's the person on a day-to-day basis as opposed to the C-suite, let's say, the champion, if it's an applied position where the person competed to get the position, the PFAC is much more effective compared to an appointed position, and the person just says, oh, it's another job to do. So find a patient-centered where people are really into the patient, and start with that department. And if there's anything that I can do to help you, I would love to.
Our favorite final question every time, I know this is a favorite of Jill's as well, and that is, do you have a favorite quote you can share? And if so, why is it your favorite quote?
So a few years ago, I was fortunate enough to take a train trip through India, and I spent some time one afternoon actually at Mahatma Gandhi's compound, which was really quite beautiful. And he said a lot of great things in his life, but one of the quotes that really resonates with me is, "Be the change you wish to see in the world." And over the course of the last 10 or 12 years that I've been in healthcare, I've just come across so many stories of people who have changed the world, who have changed healthcare, who have made a huge impact because they did something. They took on the insurance companies and it's just wonderful what people have done. And if you have that in you, if you feel that there's something that needs to change, I highly recommend and that you go out and you implement whatever you're doing and work to that, because it'll be great what you do if you can change the world.
Really inspiring, Barbara. That reminds me of the story you told about, the tragic passing of your sister, and you seem to be doing that, to be being the change that you want to see in the world. So thank you so much for such an inspiring and insightful conversation. We're really grateful for the wisdom and perspective you shared. To our listeners, thank you as well. We hope you found this discussion helpful and useful. And be sure to join us for our next episode of Humanizing Healthcare. We'll be talking with Dwight McBee, Chief Experience Officer at RWJ Barnabas Health. And until then, have a great rest of your day. And thank you.